Some of the challenges and opportunities for ICSs is bringing together data from multiple siloed systems, and then release the potential of that data. And that can be used to improve outcomes for patients and citizens, manage your performance and continuous improvement of services, and more widely gain insights into your citizens and communities. The continuing rollout of shared care records across England provides an important enabler for supporting that data interoperability. And this infrastructure has the potential to bring data together. So that can provide support to professionals in their interventions and care, as well as improve services and indeed help identify where new services could be established or where there's need that needs to be addressed. But so that could, by way of an introduction, hopefully that helps. I'm delighted that we've got Monica Jones with us today. And Monica's going to be sharing her experiences and learning from working with the Shared Care Record programme in Yorkshire and Humber, and give us some ideas more widely about how to unleash the power of your data. So without more ado, over to you, Monica. Thank you.
Thanks, Jerry, and thanks everybody for dialing in today. So I think my slides are being generated. Oh, have I got control of them? Yes, I do. Oh, excellent. As Jerry said, I'm going to talk for the next sort of 15-20 minutes on my experiences, and particularly around releasing the power of shared care records. So my current role is as Chief Data Officer for the Health Data Research Hub for Cancer, DataCan, which is a national organisation, and also Associate Director for HDI UK North, which is a collaboration across the north of England, in particular Leeds. So I work for the University of Leeds currently, and then it's Manchester, Liverpool, Newcastle, Sheffield and Lancaster. But for the last sort of 3 years, I've also been the exec lead for population health management for the Yorkshire Humber Care Record, and I'll be focusing a lot on that today. But I just wanted to sort of set the scene in terms of HDI UK, which is the National Institute for Healthcare Data Science, was set up about 3 years ago now, very much about improving healthcare data and making that sort of more accessible for researchers, whether that's academic, industry, NHS, charities, government, and public. And in order to be able to have good quality data, then essentially you need that the sources of those data, mainly through NHS and local authority sort of organisations, as well as arm's length bodies. And you can see on the left-hand side here, that is the UK Health Data Research Alliance. So that's really about signing up to the principles of improving shared care records, in particular for secondary uses. The digital innovation hubs, health data research hubs, of which DataCan is one of them, sits in the middle. They're either specialty specific like cancer, and then on the right hand side, these are a surface through the Health Data Research Innovation Gateway, which is one of the main sort of products that we've produced as part of HDI UK, and that's a publicly available sort of portal that actually describes a number of well-curated data sets. I think there are probably over 600-700 on there now, in terms of sort of standardized metadata, but also sort of what the context is. And myself and colleagues have also worked on a data utility framework, which was published earlier this year in the BMJ Informatics journal, that actually takes you through sort of more than just data quality. So it's actually about how to describe how useful data is. So I would recommend that. But specifically, I'm going to sort of talk now about my experience in Yorkshire and Humber. So as I said, I'm based in Leeds. When I started this particular sort of role as a secondment, I was actually CIO at Rotherham Foundation Trust in South Yorkshire, but moved to my DataCan role sort of about 2/3 of the way through. So, as with a lot of regions, this will be familiar to people, that, you know, we've got various sort of health challenges in terms of life expectancy, in terms of comorbidities, in terms of challenges. We cover a population of approximately 5.5 million citizens, 22 acute trusts, 15 local authorities, and 770 GP practice, and 3 integrated care systems. So the Yorkshire and Humber region covers West Yorkshire and Harrogate, South Yorkshire and Bassetlaw, and Humber Coast and Vale. So we decided we were one of the Wave 1 LICRAs. So we got the central capital funding from NHS England in 2000, started in 2018. And the idea was essentially to sort of build on best practice and exemplars, and the Yorkshire and Humber Care Record, along with the other 4 regions, which was Manchester, 1 London, Wessex, and can't remember what the other one was. Sorry about that. And so was really to try and bring together existing records across the various sort of systems, across our sort of ecosystem, so that clinicians can spend more time with people and in their care, improve connectivity and integration, better decision making, reduction in tests, which sounds all, you know, absolutely grand sort of ambitions, but you know, making that happen is a lot more sort of difficult. So we decided to take very much a sort of a bottom-up approach. Those of us who survived the National Programme for IT know that some of the lessons learned from that were that centralised heavy engineering imposed on people doesn't work, that actually sort of giving people the autonomy, but actually basing things on open standards and interoperability is a far better way of getting not only sort of engagement, but also building things up incrementally. So there are 3 strands to our solution: the integrated care record itself. So this is for direct care in terms of better decision making and saving time. Then the patient health record side of things, so that people are actively involved in their health and well-being. And then the improved intelligence. So this is very much focusing on population health management, secondary uses of data, and actually making the most of the fact that we've been joining everything up in terms of our integrated care records. The byproduct of that is that we have well curated, good quality data for secondary purposes. I've got a few sort of stats sort of figures here, which I think are actually really quite good in terms of sort of, you know, the illustration. So in terms of digital health technology, then this is just, you know, a comparison with the NHS app sort of registration. And in terms of the uptake in Yorkshire and Humber, it's actually been pretty good, you know, higher than the national average. And there is a good level of engagement. I'll come on later in my presentation to talk about some of the public consultations that we've done. We absolutely believe that the citizen is at the heart of everything we do, hence the logo of Yorkshire and Humber Care Record, which is indicative of the 3 ICSs, but actually putting the citizen at the centre. In terms of the registration of national opt-out, once again, we've got a lower rate than the national average. We think a lot of that is because of the engagement that we've done across the region, and you can see some of the figures there in comparison with the national totals. Adoption of personal health records. We've also had a big drive, not only through the Yorkshire and Humber Care Record with the Helm product, but actually there is a lot of other things sort of happening across our 3 ICSs. So particularly in Humber Coast and Vale, specifically at Hull Teaching Hospital, and a lot around end of life and EPACs. West Yorkshire and Harrogate, the Bradford system through the Born in Bradford programme, and then also Kirklees Council and Calderdale Foundation trusts of individuals accessing their patient portal. And then in South Yorkshire and Bassetlaw, Rotherham, where I used to work, the Rotherham Health app was sort of rolled out as part of the Rotherham Health Record, which is an at-place shared care record that actually sort of is one of the sort of leading exemplars across Yorkshire and Humber and Rotherham. Punches above its weight in terms of that, and that really came out of some of the issues that Rotherham had that were widely reported in the press, particularly around sort of some of the child abuse issues. And what I found that when I was working at Rotherham, particularly working with the Rotherham Council and the CCG, is that what came out of that scenario was that people really genuinely understood the need for shared care records, particularly from a safeguarding perspective, but that also then accelerated our ability to be able to link up across the integrated trust of both acute and community, which by default means that you have to have a longitudinal record plus the 30 GP practices and with the Council for both adult and children's social care and shared mental health services with RDASH. So in terms of progress and plans for the future, the Yorkshire and Humber Care Record is delivering innovative solutions and tools to meet the region's need. The momentum we've created will be sustained. And actually, we have a digital charter now with across the 3 integrated care systems. And because we were one of the Wave 1 LICRAs, we've actually helped and supported other regions. As I mentioned earlier, we took the approach of actually building on open standards and interoperability. So we don't actually have a persistent data layer for our direct care. We essentially build a longitudinal record on the fly using HL7 FHIR, and we have FHIR profiles. And so that actually is then surfaced through whatever portal is used at a local level. So for example, if I'm a clinician in Leeds, I would log on to the Leeds Care Record, and I will see not only the screens that are relevant for a patient within the sort of the Leeds setting, but also the shared care records. There'll be additional tabs. So particularly for some of the pathways, and we've done a lot of work around cancer pathways. So if somebody has a suspicion of cancer in say Rotherham, they'll go to their GP, that would get a referral to Rotherham Foundation Trust. Initially, they would probably get a secondary referral through to Sheffield as the largest cancer centre around. But if there are particular, rare disease or needing specific treatment, then they'll, there are a number of people who would get referred to Leeds. And and in the past, all of those things would actually sort of happen separately. There was a whole load of duplication in terms of tests, diagnostics, and particularly with a cancer pathway, time is of the essence. So what, as I said, the oncologist in Leeds would be able to log on to their system and actually look at everything that happened to that patient from Rotherham. Likewise, when the individual goes back to Rotherham, having had their treatment, their surgery, their chemotherapy, etc., then the GP in Rotherham would be able to actually, through the Rotherham Health Record, see that same sort of pathway, but it's built up on the fly. And initially, we got a bit of a hard time from NHS England because they thought we were barking mad, really, to try and do it this way. But we proved that the technology worked, and we went from 0 to hero fairly quickly. And they went, "Ooh, that's rather clever." So that's the approach that we've continued to do. So we have connected a lot of our organisations for direct care, and we hope to have that all done by the end of 2021. We'll be connecting all of the social care by the end of 2022, and all organisations should be connected by the end of 2024. These are just some of the organisations that are currently connected. This is probably a bit out of date because actually we've had a big push, particularly around the Humber Coast and Vale recently, in terms of some of the sort of connectivity. And what it happens very much on a bilateral basis, that when an organisation is ready to connect, then actually we do all of the preparatory work, all of the patient safety sort of assessments and testing of the connectivity, and actually then sort of connect, do an end-to-end sort of test using dummy data, and then actually follow it through. And we're building up the fire profiles as we go along in terms of the scenarios. So from a population health management perspective, so this is the area that I've been leading on. The approach that we've taken, and there are a number of methodologies that you can use, but this sort of wheel of fortune, as I describe it, is the methodology we've applied in Yorkshire and Humber in particular. So it's very much an iterative approach, defining your population mainly through population segmentation, so that you actually know what the characteristics of your population are, identifying care gaps through that sort of process, slicing and dicing the data, and then sort of using risk stratification. Now, classically, in the NHS, our risk stratification tends to be, in primary care, it tends to be about avoiding hospital admissions. But actually, when you've got much more sophisticated approach to population health management, you can do much more predictive analysis and cohort identification. Then it's about engaging with the patients and through that, direct contact with either their GP or through other healthcare providers locally. And then it's about managing the care, measuring the outcomes. You've got to know what your baseline is before you can then say whether you've got there or not, and then back round the loop. Hinges very heavily on the use of new technologies and richer information. So we actually built a platform as part of this. It's based on Google Cloud Platform. It's a GCP. Frankly, if you're doing this sort of large kind of data analytics, then using a cloud-based environment, whether that's Google, whether that's Microsoft, whether it's Amazon, or whether it's a locally developed one, is really sort of the best approach. It allows you to be scalable, and it also allows you to leverage the technology. We went through an open procurement through the HSS framework. So of the £7.5 million that we had from NHS England for our programme, 3.9 of that was spent on the population health management platform. But being canny Yorkshire folk, we decided to not burn up all the cash up front, and actually a 5-year contract from July 2019. So that runs through till 2024. And this is all up and running and functional. The data comes in through our system of systems into our integration service, our analytic platform. It has all the security management and has a service management wrapper around it. There are a number of analytic products, and basically anybody who is health and care provider organisation or commissioners within Yorkshire and Humber can use this for free. And then there are a number of developers. Those are colleagues who build the analytic solutions using the platform. And then the consumers of that are commissioners, health providers, clinicians, health and care workers. So that's working very well. This is the type of sort of dashboard kind of products that we've got. This is a strategic analytics segmentation model at PCN level. So the level of the data, because it's coming through from at an individual sort of record, allows us to do some really quite, sort of detailed sort of analytics around this. And this is particularly around emergency admissions with cancer. There are a number of others. So how does that actually work? So as I explained, our system of systems, which is essentially the direct care element, then somebody's comments appeared on there. Comes into the system of systems, and it builds a data set to satisfy the query. We've baked into our solution the national opt-out. So if people don't want their data to be used for secondary uses, then that is automatically removed. And it then comes into the data collector. Now we have an arrangement with NHS Digital to use the National De-Identification tool, Privitar, for pseudonymisation. In order to be able to do that, we actually went to the Confidentiality Advisory Group and got both our CAG approval and ethics approval in order to be able to do that. And then NHS Digital acted as a third-party processor for us to pseudonymise the records for linkage. Theoretically, you could re-identify that for risk stratification. We haven't enabled that because we wanted to take a stepwise approach. And also really just some of the feedback from our consultations was that people just weren't quite ready for that. So we listened to that. In terms of that, then goes into the de-identified data is then stored for population health management analytics. We also have built a query builder that means that analysts can actually go in and build bespoke data sets. So any organization that is connected into the shared care record and has agreed to sharing those records, then actually the analyst can pick those in a standardized way using the FHIR profiles and actually then generate the analytics. This is real-time data that is coming in, and it also sets up a subscription service so that if there are any updates, it automatically updates the queries. We also have the facility for bulk upload. So if there are large linked, curated sort of data sets, pre-anonymized ones. So in particular, as I mentioned earlier, we've got the Born in Bradford and the Connected Bradford data sets, which have been running for many years. They've already got their own IG and ethics. They needed a home to land in. So we've actually lifted and shifted those into the Yorkshire and Humber Care record. And it has also meant that the colleagues are being able to access that throughout the pandemic when we've all been working remotely and not having to physically go on premises in order to do that. We've got some large data sets from Leeds, in particular, a comprehensive patient record, which is a linked primary and secondary care cancer data set in there, and a number of others. And we've done quite a lot of COVID work, and we're working with sort of colleagues across the ICSs to support that. So I mentioned that we'd done some consultations. We absolutely wanted to know that we had the trust of the public around how we use the data. So we've done 3 engagements. This was the first one that joined up Yorkshire and Humber. And it was really sort of post-GDPR, post-Cambridge Analytica, sort of, what did people genuinely think about shared care records? These full reports are available on our website, yhcr.org. Everything is in the public domain, all the technical documentation. There's lots of videos, there's lots of user case stories that are on there. And we were actually very pleasantly surprised that 95% of the population who we engaged with were supported of one or more use. There was very strong support for public health uses, screening, health advice. Not unsurprisingly, concerns about data sold to private companies or not stored securely. So we've, made sure that we have a full cybersecurity sort of penetration testing and reports that are available that shows how secure the system is. They, some of the direct quotes were, "Please don't sell it to the Russians and don't give it to those people down south." So we're not doing the first, but we're working on the sharing it across the UK. But this is very much a Yorkshire number, and there's a real sense of identity associated with it as well that I think brings with it an element of trust. There is a Yorkshireness about this, and people can actually see it is relevant to their life because they do move around the region for their health and care. So just a couple more slides, really. Now, also, I was really determined that we would not just build this on the tech, that actually it had to be about the people as well. So I wanted to upskill our workforce to be able to use, this fantastic technology. So we set up the YHCR Academy. We've had a cohort that's gone through that of 40 delegates of both, analysts, clinicians, managers, leaders from across the sort of the region in order to educate them, provide the analytical tools, develop the talent, and build strong record networks. We did it just for population health management the first time, but we're extending that to include our integrated care record. And we're just developing with Health Education England a whole set of modular online learning, as well as actually sort of some of the face-to-face stuff that we did previously. So it's got scalability, it's got extensibility, and also cost effective. So I'll just finish off in terms of sort of what we're doing from a DataCam perspective. When the call came out for HDR UK for the hubs, we put in a Yorkshire bid. The feedback was that it was strong, but if it was going to have legs, then it needed to be national. So we then reached out to colleagues and partners in London and in Belfast in particular. So this is a consortium of 6 founding partners. University of Leeds, where I work, Leeds Teaching Hospital, Queen's University Belfast, UCL Partners in London, which is a host organisation, Genomics England. And because this is part funded through the Industry Strategy Fund, then everybody had to have an industry partner. So IQVIA are our industry partner. They provide a lot of clinical trials in the UK and across Europe. Our aim is, as you can see, to improve access to existing data, improve the quality of data, improve the coverage, and add new data sets at scale in order to improve access, but also show fair value to the NHS, to trusts and CCGs and patients and public. What we've been doing recently, obviously, like everybody else, we've been responding to the global pandemic. And last year we did some pretty rapid sort of analytics when we saw sort of during the first lockdown this massive drop off in terms of 2-week wait referrals. About 70% of cancer patients were not getting a referral from primary care, and also attendance for chemotherapy, radiotherapy, and other therapies was down by about 40%. And you can see the drop off here in each of those areas. So we pulled together really as a call to action, not only to the government, but the CMOs across all 4 nations, really saying, if this continues, then the impact in terms of excess deaths of people who are affected by COVID, who have cancer, could result in between 7,000 and 18,000 additional deaths. What we've now been doing is working with NHS Digital, with the National Trusted Research Environment, the TRE, which brings together the standard data sets, such as HERS, SUS, mortality prescribing data, with all of the COVID data sets, the Pillar 1, Pillar 2, and the vaccination data. That's then linked in their environment, the DAE, once again using Privitar tools, a very similar approach to what we've done regionally in Yorkshire and Humber. And we've got essentially access to pseudonymized data for more than 50 million patients in England, 12 billion rows of data, in order to be able to do some very detailed sort of analytics and research, to prove whether the modelling from last year was right, but we're also seeing missing diagnosis in the system. And as we all know, that if somebody presents at a later stage with cancer, then the outcomes are far, far worse. We reckon in Leeds alone, there's about 1,500 missing people, and that would extrapolate up to about 85,000 missing people in the system. So that's the effect of COVID on cancer. So some really important work that we're doing there. So that's a quick whistle-stop tour through my world, and I'll stop there and leave it open for any questions. Thanks very much.
Thank you, Monica. That was really fascinating, and just the idea of a really complex journey, but kind of keeping going and getting some positive progress and outcomes at the end. So thank you very much. Daniel's asked, when you say social care, do you include social care providers within that used as part of that wider social care kind of cohort?
Yeah, I mean, most of it is sort of local authorities essentially as commissioners, but also providers. So we are doing some work, particularly across HDR UK North, particularly around frailty, and that includes care homes and digitisation in care homes, and also some medicines management around sort of the effects of antimicrobial prescribing and so yeah, it does extend to that. It's, as I said before, it's sort of very much on an incremental sort of basis, and it does depend on the digital maturity. So we're helping wherever possible. We've done a lot of work around end of life care, particularly in Humber, so working with hospices as well. Yes, so it's still work in progress, but yeah, it does include that.
Thank you. I've got maybe one or two questions I'd like to put to you, if that's okay. One, which I think, I know this is an area that you of interest for you. How important are standards in terms of supporting the effective sharing and use of data?
Yeah, I mean, I'm a standards kind of girl. I've sort of worked in this kind of space for a lot of years, and you can't have quality without standards, and you just make life very difficult for yourself if you don't, because you just can't compare apples with apples or even apples with oranges as long as you know that they're fruit. So I think it's and particularly with the Yorkshire and Humber Care Record, as I said, we've built it very much on HL7 Fire in terms of our interoperability, but we've also got some standardized data models within the system. So, for example, the Connected Bradford is described using OMOP, which is an international standard for data modeling. So it just means that the format of the data that it's in, if you can apply it using standardized models, then actually your ability to scale in a cost-effective and an efficient way, where you have to do less and less data wrangling, it is actually a very good thing. It also integrates very well with Google BigQuery, which is fantastic. So yeah, I think it is very, very important. The metadata gateway that I talked about very much is around creating a set of standards so that people can understand what is in the data sets without having to have access to the data to see whether it has that utility. Otherwise, it's all just a little bit of a mess. And you can spend such a long time actually trying to get the extracts into the right sort of format, whether that's for operational use, working within an NHS organization and in a trust, or whether that's actually sort of at a place-based or a regional level, in order to be able to do that. You're on a hiding to nothing if you don't actually try and describe things in a standardized way.
And kind of following on from that, I guess, do you think it's time that, particularly when you're looking across wider communities like ICSs, that actually information strategies could be useful documents?
Yeah, I think it's very important. As part of the build-up for describing both the STPs and then the migration to ICSs, we all had to produce a digital roadmap. And underpinning that is, a really good sort of information strategy. And I know that it's a subject very close to and dear to your heart, sort of, Gary. But I think it is something that we absolutely must sort of embrace. In terms of sort of knowing where we want to get to, what the principles are, what our approach is in terms of of both our strategic sort of direction, but also how we operationalize that. So I think it is very important. I think as data becomes more and more part of our everyday lives, and I think everybody has recognized that as part of the the COVID pandemic over the last sort of 18 months. Even my 83-year-old mum, could actually sort of quote you the daily briefings, the COVID briefings, you know, in terms of, you know, what the rates were, what the hospitalization was, what the R number was. You know, people, it's in common parlance now to actually expect real-time data and actually meaningful data. Then I think it's beholden upon all of us to be able to describe how we are going to get to a better place, and what the component parts are of that.
Monica, thank you. That's excellent. I'm thinking perhaps we'll move on now to perhaps look at something a little bit lower down in the chain, but an up and coming data generator to feed your ever growing data lake. So I wanted to talk a little bit about unleashing tech data, so technology enabled care data. And as you can see from the slide, I'm going to talk through a little story through just this one slide, but we can see that primary care and acute are both commission and provide tech data and tech devices rather, as do adult social care and children's services, who primarily do a lot of commissioning around these sorts of services and devices to support people and their independence in their home. Most of the provision of this is certainly from a social care perspective, is within the third sector, although sometimes it's elsewhere within the local authority, but not necessarily sitting in adults social care, where it tends to be. But finally, and more interestingly, kind of citizens and patients. So when someone presents needing support or help, often they've already got some of this infrastructure already in their homes, be it a smartphone or be it maybe a sensor that either themselves or extended family have suggested would be a good idea. But we've seen the growth of use of these technologies through the COVID pandemic. And certainly we've seen a growth of the kind of devices that can enable people to be supported remotely through conversation assessment and to some extent through service delivery. So as this grows and as the kind of pressure on resources in terms of the actual people being available to deliver support and care, either in a kind of clinical setting or at home, this area is just going to grow and grow and grow. So the amount of data that's going to be created is going to grow and grow. But what can we actually do with this data? At the moment, it's pretty siloed. I don't think it's very accessible to what you might call your mainstream systems. So we need to be able to funnel this data into a platform and then use it in a range of ways, which I've kind of describing here. So, and although current sort of systems, a lot of systems in social care are alarm based and just do an event one-way trigger. Actually, we're starting to see platforms emerging in the market now that actually are able to, yes, manage with those triggers, but actually push reminders and nudges and messages to people to remind them to drink if there's some hot weather coming along, or to keep warm if there's a cold snap coming along, etc. But actually there's starting to be two-way alerting and responding, and this data can support that. It can also support pathway and case management, so where we're supporting individuals, and that can be done via a shared care record, which Monica's talked about earlier, and that can move down into review work that professionals and practitioners are doing, and also it can help where someone's in a discharge setting. So if a discharge team can actually see that this person's got some technology-enabled care in their home, that might speed up their discharge because there's already some infrastructure in there that they can take advantage of, and also that continues that data feed. Obviously, the data can be there to support your performance management. That's, you know, at the operational level, but also I think more interestingly, it can be used to kind of support your service improvement and developing your services so that they're more responsive and they meet the needs of the people that you're serving. And then finally, obviously, all that analytical data, which Monica's spoken an awful lot about, and the use of artificial intelligence and machine learning and the like to kind of generate those insights that you need across your communities about your services, and more generally about impact of services across your community. I think there's one more clip, please, Bobby. Thank you. So, and in some ways, it sounds quite straightforward what I've just said. We just commission some devices, we capture the data and we use it. But actually, unfortunately, the world isn't quite that straightforward. And again, Monica had already alluded to this around things like standards and information governance. So there are so many devices out there. There aren't any. There are numbers of standards as well. So it's quite difficult to sometimes to bring that data in and to make those devices interoperable with these platforms that can gather the data and then make use of it. And then something that's emerging as an issue, I think, particularly where we're looking at citizens and patients maybe using their own individual devices, is actually digital inclusion. People may not be able to afford those devices or afford those a broadband or digital connections at home. And how do we actually do that? I think if there's an assumption that everybody's got access to the internet and access to digital devices and can confidently use them, the evidence suggests that's not the case, and significant numbers of people are excluded from accessing services and information using those channels, and that's something I think that we're going to see more and more about going forward. So what I've tried to do with that, Bobby, could you go back? Sorry. So what I'm trying to do is try and give a kind of real world example of how what data is available and how we can bring that in. But interesting for me, this area isn't really on the agenda at the moment for shared care records, particularly, and I think this is a really important area that actually needs some attention. And it'd be interesting if anybody's got any views about that, whether they think I'm on the right track, or whether I'm underestimating the challenges maybe that there might be in this area. But I don't know if anybody wants to kind of come back or respond to this, what I've just said. If not, we can move on. But I'll just give people a chance if they want to ask anything. Okay. Right. Thank you very much. Okay. So what I think when Monica and I were talking about this session, we thought it would be useful maybe just to kind of list half a dozen things that we think would be useful perhaps for you to take away and think about when you're going forward in terms of working around trying to get the best from your data and releasing the power of that. So we've already mentioned this, developing an information strategy. I think these are really important. I think we've used them in the past in local government in sort of in the 2000s, and they've kind of gone out of fashion a little bit. But I think the whole information landscape is so much more complicated now. I think actually information strategies help bring that focus again. Engaging with standards. I think Monica's given a good kind of explanation as to why standards are really important. They are chipping away at us. So the Professional Record Standards Body is doing a lot of work around health and care standards. Most of it focused around the provider side, but actually starting more to look at the how local government data can be brought into to standards. Listening to and working with your stakeholders. I think in terms of moving forward, with the data that we want to bring together, they come from different areas, different functions and support for people, and there are different languages, different expectations, and different cultures. But it'll be difficult to work if you don't actually listen and try and work out how the best way of moving forward. I think across some of these large areas and communities that Monica was talking about, we know that lots of organisations are at very different levels of maturity. So when there's an expectation that someone will come to join the party effectively, but actually they don't have the capability to join, but the assumption might be they have, then how do you actually help people come up to a level so that they can participate in this work? And building those sort of strong relationships across multiple organisations. We think joined up teams that are actually sort of brought into being as being together teams. They're not still, they may have one foot still in their original organisation, but their primary commitment is to this new joint team to actually try and deliver these data ambitions. And I think finally as well is to kind of start exploring and having conversations around how that shared care record infrastructure can be extended to support tech, which I've just talked about, but there's lots of other organisations which we haven't included in our conversation, like say domiciliary care provision, housing organisations, and education sitting in behind children's services, and there's no reason why that infrastructure can't be extended to kind of bring those other organisations into that shared record arena. Bobby, could we move on? Yes. So in terms of, this is the second of 3 briefings that Sofitim have commissioned. We've got another one next week on successful partnership working. And on the back of this event today, we're looking to plan a round the table event, possibly in January, to follow up on this briefing, and then give an opportunity for some more reflection on some of the things that we've identified through the briefing. I think we've come to the end of the briefing here. Has anybody got anything else they just want to share or want to ask before we call this to a close? I'd like to thank Monica for her presentation and slides. Very good stuff, and we look forward to meeting some of you again. And I think, unless there's anything else, I think that's us come to an end. Thank you very much. I'm getting some thank yous in the chat. Excellent. Good. Well, that's it. I think we'll leave it there. And thank you very much to everybody for attending. And hopefully we'll see some of you soon. Thank you very much.
Okay. Thank you, everyone.
Right.